welcome. It's my pleasure to introduce Dr. Angela Dispenzieri. She's a professor of medicine and laboratory medicine at my clinic. She's a world lead distinguished consultant in treatment of myeloma, and she has special interest in amyloidosis. She will talk about bridging and washout period for apheresis in patients with multiple myeloma.
Well, thank you for inviting me, and thank you for your attention. So this is an interesting topic. Unfortunately, not tons of data, so I will do my best to give you expert advice and consensus and all the rest. My disclosures, and again, warning, limited data on the topic. I am going to talk a little bit about CD34, so before stem cell transplant, prior therapy, how it affects that, and then we'll move to CAR T in terms of apheresis and bridging. Okay, so CD34 cells, despite the fact that we've been doing stem cell transplant in myeloma for almost 40 years now, there really are mostly retrospective information about what affects what, but we know a lot of things. We know age, we know what mobilization regimen you use, we know what prior therapies, and we'll talk about that. If the bone marrow, if there's a lot of myeloma in the marrow, it's harder to collect, and hemoglobin is also a risk factor. Now, we know a lot of our therapies will reduce stem cell yield. Even thalidomide, there's data to show, if you compare it to the old-fashioned drugs like vincristine, adriamycin, dex, or just dex, the yield is reduced. Not to say that we wouldn't want to use these drugs because they are effective, but they do reduce the stem cell yield a little bit. Lenalidomide certainly does reduce stem cell yield, and it's thought to be dose dependent, and also it is seemingly worse for stem cell collection than daratumumab. So this is a study out of South Korea where they were trying to really look at how much each drug perhaps affects the ability to mobilize stem cells. And again, it is retrospective, so there's all types of caveats. But you can see in the first column, it's bortezomib, thalidomide, and dexamethasone. The next column is dara, VTD, and then the last is bortezomib, lenalidomide, and dex. And there are differences among the patients in terms of how many induction cycles, how many VGPRs they got. But most importantly, whether it was used as GCSF alone was used for the mobilization. So again, you can see 79% in the VTD, 94% in the DVTD, and 88% in the VRD. But you can see that the number of CD34 cells collected with the first apheresis is lowest in the VRD and second lowest in the DVTD and best with the VTD. And if you look at the numbers of days of mobilization, more days required. If you have the lenalidomide in there, more need for plerixafor, and actually even a slower time to ANC engraftment post-transplant with the lenalidomide and even the dara-containing regimens compared to just a VTD regimen. There's a very nice review that was looking at the impact of anti-CD38 monoclonal antibody therapies on collecting stem cells in myeloma, and basically this is the summary. What you can see is the pink means that no significant differences, and the dark pink means that there was significantly different outcomes in patients given mostly daratumumab. There's one isatuximab trial in here. And then the numbers of patients in each study, so the weighting. And what you'll note there is that basically infections are no different. So using an anti-CD34 antibody as part of your induction isn't going to affect infection rates. But it does slow platelet recovery by maybe a day or two is the composite. It does delay neutrophil engraftment by perhaps a day or two. Leukapheresis is more, you need more leukapheresis sessions. You're more likely to have target failure, more likely to use plerixafor, more likely to have fewer CD34 cells, and lesser yield. And this is very complicated, not expecting you to understand, to read this, but this is essentially what went into this meta-analysis, how they did. So again, a lot of patients, a lot of studies to try to give the answers that I just shared with you. And so it was 27 studies, and only one had isatuximab and 1,600 with daratumumab, and the most common inductions were dara-VTD followed by a lenalidomide containing regimen followed by a Cytoxan containing regimen. And again, it was really looking at the randomization of do you have CD38 antibody or not. Okay, so what about the number of induction cycles on your ability to collect stem cells? The short answer is we don't know because the data are very variable. It's never been, systematically looked at, but this is trying to pull what you can get out of the literature. And so this one study, DARA-KRD, showed 27% failure when 22 patients underwent mobilization after 7 or 8 cycles. And they say collect after no more than 3 to 4 cycles. But then another 2 studies were comparing collection outcomes between patients receiving 12 or 16 daratumumab doses. And they basically said there was not really any significant difference. They also looked at whether the time between stopping the daratumumab to the time of starting collection, whether that mattered. And again, very small numbers of patients, so very hard to draw any true conclusions. They said it made no difference, but is that a power question? I can't answer. And another study said receiving more than 4 DARA VRD cycles did not impact the first day harvest. So again, take it as you will. I think that what we do know is that these therapies are effective. We want to use them. We don't have perfect data in how to use them, but with plerixafor, you can definitely make up for some of the deficit that you have. And so again, this is a compilation of different studies saying, but look at the cost, it's an expensive drug, and perhaps by altering, what your threshold, if you use on-demand plerixafor, does that make the difference in terms of if you use a higher threshold, then you can save a few more doses. You also have to consider the numbers of days, the cost of drug versus the number of days of leukapheresis. How much does that cost you and your patient? And then also, if chemomobilization is always an option, you can get more stem cells out of a patient, but you're adding an extra week, you're adding, days of neutropenia and all that supportive care. So there really isn't a correct answer. But despite the fact that daratumumab and lenalidomide can affect your collection, there are ways around it. So by no means, one shouldn't say don't use these drugs, but just be aware of that. We use on-demand plerixafor, and these are our thresholds. We count on day 4, we see what our CD34 count is and go from there. So in terms of recommendations, in terms of leukapheresis, we basically know that we can reduce our yield by using these therapies, but they are excellent therapies, so we will continue on. And there are ways around the problem, and basically there's little data on the time of washout, but most of us would say somehow something weird happened. Basically 14 days between. Some authors will say use 28 days for washout for daratumumab, but I don't know that that's really a valid data-driven recommendation, but definitely 2 weeks. Okay, CAR T. So this is really mostly based on consensus guidelines, based on the limited data that exist. We know that there are things that will affect a patient's ability to collect cells and to actually get their CAR T. We know that bulky disease, bulky myeloma disease at the time of the CAR T and even at the time of apheresis can affect our ability to get a good product and ultimate outcomes. And basically, severe cytopenias, if you give chemotherapy, it's going to be harder to collect cells for your apheresis product for your CAR T. And alkylators definitely can adversely affect your lymphocyte counts and then the T cell fitness. So now that we are able, we just heard that lovely talk about CAR T and that how it doesn't have to be after 4 relapses, you can use it after 1 or 2 relapses. That urgency of, trying to find something to use. If it was after 4 prior lines, patients had been through everything, refractory to everything, you're trying to guess what to use. Now you can take your time, you can think about it at first relapse, second relapse, and this idea of giving chemotherapy prior to apheresis or trying to get the disease under control is less of an issue. And so, the expert opinion is, avoid lymphotoxic agents, ideally a couple of months before you're going to get your apheresis product. So you don't want to use alkylators or fludarabine or very high dose steroids. For most therapies, for most myeloma therapies, a 2-week washout is very adequate. Drugs like venetoclax, low-dose corticosteroids, you might even be able to get away with less than 14 days. But if you can have patients off drug for 14 days prior to apheresis, that's a good thing. And then radiation, if it's a small volume of radiation, it's felt that that's safe to do prior even to apheresis. In terms of prior therapies, so we all are aware that there is a failure rate in collecting our cell or making our product. And a lot of specimens may be out of spec, 10 to 20%. BCMA, prior BCMA therapy definitely affects your product. So we already just heard, the order of things, try not to be using certainly anti-BCMA bispecific prior to your CAR T. And so again, definitely the product is less good if you use teclistamab or elrantamab prior to collecting your cells for CAR T. Now this is trying to make some information out of a very limited number of patients. And so I'm going to talk you through this because it's part of a bigger study, 52 patients with different bridging, 10 of whom had bispecific antibodies, 5 teclistamab, 5 talquetamab, period. 9 of 10 of these had their first dose of bispecific before their apheresis. So if you look at that plot on the right, the 5 patients above the blue line are anti-BCMA, they're teclistamab. The 5 on the bottom are talquetamab. And the stars are basically whether there was a successful leukapheresis. And the orange is an out-of-spec product. Okay. So if you look at the above the blue line, you'll notice that there are a number of orange stars. Each of the stripes on the top, the orange stripes, those are doses of teclistamab. So you can see that they may have gotten several doses of teclistamab, but you see a lot of them are out of spec and eventually got successful black star collection. In contrast, if you look at the talquetamab, which is the bottom 5, you'll see that you have more black stars without orange stars. But again, very limited data on use of teclistamab prior to apheresis. There's a lot more on bridging, but in terms of apheresis, we don't know. And there are some data that you might, if using teclistamab, you might even have a better CD4 CAR T cell profile, so in some ways it may prime. But I think that the recommendation right now is, if you had to have had a bispecific before your apheresis for your CAR T, don't let it be teclistamab, let it be talquetamab. And this is just showing that the different lymphocyte subsets having higher CD4 cells, early memory cells, will basically give you better long-term response. And so more study needs to go on in terms of what what you have before your apheresis to determine if you're going to get this profile. We heard this before, is prior exposure to BCMA-directed therapy affect BCMA CAR-T. The upper half of the slide is referring to ide-cel, and what happens, the upper bar is saying no prior BCMA exposure, and the other is following BCMA exposure, and what you can see is that you have a lower overall response rate, a lower CR rate, et cetera, if you get BCMA prior to your CAR-T, and there's the PFS to the right, with the blue being no prior exposure. Same for cilta-cel, less CR, less overall response if you had teclistamab or another BCMA-directed therapy prior to your CAR-T. Okay, bridging. So bridging is very common, especially in the early studies, because again, patients, it was 4 prior lines, and so patients had tumor burden, and a lot of patients couldn't even get to CAR-T because their disease was so rapidly advanced, and all the rest. So it was a very common thing. I think as we move into earlier line, this will be less common. For patients who have no measurable disease after bridging therapy, there's this theoretical question: if you don't have any myeloma cells, if the patient's MRD negative at the time of doing your CAR-T, will that affect your CAR-T persistence and expansion? It's theoretical. We know that if you have a CR, you do plenty well, but a hypothetical problem. The existing guidance would suggest, for now this is for bridging, a washout of at least 1 week or 5 times the half-life of the agent between bridging and the leukodepletion therapy. And radiation is potentially recommended if there's extramedullary disease, because that may help with these extramedullary plasmacytomas. But again, less of an issue now that we have earlier line use. And this is a sort of real-world kind of compilation of how bridging therapy influences outcome after CAR-T therapy. On the right, it shows you overall response rate to bridging therapy. Only 8% were in CR. But then if you look at PFS relative to how well you did with your bridging therapy, the blue line are the CR patients, but it's only 4, so very few patients. And then you have your VGPR and your PR. And then again, looking at how you do post-CAR-T with each of these different therapies. Patients are getting high response rates with these therapies, and then CRS is no higher than expected with any of these different agents. And then this is telketamab data, so using GPRC5D targeted therapy as bridging. So you now have your product, you have to wait 4 weeks to get your CAR-T, and here you are, what do you do with your patient if they're progressing? And so this is a compilation of patients who got telketamab, a GPRC5D bispecific, and what you can see at the bottom left is that the expected infection rate, neurotoxicity, ICANS, CRS is no different than what you'd expect. These are the numbers, you saw the numbers before. So it doesn't seem to hurt us in that regard. And then on the right, what you can see is the progression of response. So the bars that are on the left are showing what you got with your telketamab, and then how after your CAR-T, the green goes up. There's more CR and response, and there were 11% who actually never got to their CAR-T in this series. And so the expert opinion on bridging therapies, if there's a high disease burden, you want to drive down the disease, since higher rates of ICANS, CRS, and these other complications when there is a lot of myeloma in the marrow. If there's low disease burden that's not rapidly progressing, you could consider minimal therapy to limit the disease progression while you're waiting for your product. Preclinical data suggests that immunomodulatory drugs and anti-CD38 antibodies actually may improve T cell function and CAR T activities, but limited data there. And then given the potential for CAR T cell manufacturing failure, avoid alkylators if possible for bridging, because in case your product is out of spec and now you have to recollect for that, you know that it does affect the apheresis product. And the effect of other BCMA-targeted therapy immediately before CAR T is unknown, but definitely, I would say, not recommended. And I would probably say that it's bad. But in contrast, talquetamab has been successfully used as a bridge. And with that, I'd like to thank you for your attention and questions later, I guess.